Now we are moving on to the next topic, which is pterygium and cataract. We are going to have two case presentations, one by Dr. Srivalli and the other a video presentation by Dr. Jaya, and Dr. Rama Rajagopal is going to be the discussant.
Yeah, good evening everyone. Once again, welcome to the latest version of the cataract update on the 13th of February, Friday, 13th of October, Friday the 13th. So that's a day when all the things which haunt you are supposed to come out. So I just wanted to say that this side of the auditorium, which is sitting silent, all the things that are haunting you about corneal problems of cataract, we are here to try and solve those for you. We want a little more interaction from all of you. So I think I'll stand here and talk about it so that you all also are going to, participate in it. So mine is a pretty straightforward case. Pterygium had come up as the most common thing which was troubling people when we took the Google form. So it's a case of bilateral pterygium with cataract, and even though the pterygium was bigger as far as the dimensions was concerned in the left eye, it was more flat and atrophic, whereas the right eye had a more heaped up pterygium, and the cataract also was denser in the right eye with a lesser vision of 6/60, and the keratometry mires were irregular and more than 2 diopters of cylinder in the right eye. So I took her up for the right eye pterygium surgery, which was done with a conjunctival autograft and a fibrin glue. Post-op 1 month, quite a satisfactory outcome of the keratometry reducing to about 0.5. So with this, we then calculated the IOL power, and then we had a fair amount of, we had this value, and I usually go for a 0.5 myopic. So then I took a 25.5 for the right eye. 6 weeks gap, and we did this sequential cataract surgery. So 3 weeks after the lens was implanted, and then the patient is showing quite a good outcome of 6/6 with a 0.75 SIL, and the keratometry value remains stable. The left eye, if you had been observing, every time we are doing the K reading was coming a little different. Sometimes it was 1 diopter, sometimes it was 1.25 diopters, and it was always, irregular mires. By this time, the patient was happy, but a little tired of coming to the hospital, I think. So she was like, can we just do 1 surgery and not do 2 this time? So then, and even I felt that it was a flat atrophic pterygium. So what I did was, I thought I'll leave the pterygium as it is because I didn't want to do a combined surgery. And so did the topography to take the K reading. Now, I just wanted to put up that we did the IOL calculation with all the methods by taking the manual K, which whatever we could get in one value, it was showing us a power of maybe 26. With the IOL master K, 26, and then with the topo sim K, which we took, which was coming as 25.5. Because the other eye had a plano spherical refraction, I decided to go with a slightly myopic in this eye, and then used a 26 power lens. And 3 weeks after the second eye surgery, she is doing well, and she had a -0.5 spherical with a -0.5 SIL. And this was a happy coincidence. I really did not do anything about it. God is kind. Sometimes it was an oblique kind of astigmatism, and so it has come down. So this is just to bring the discussion on to the pterygium, that different things may suit different pterygiums. So whether we have to do sequential or whether there is a role of combined surgery also. In sequential, definitely the better corneal clarity is there. We can have a better refractive prediction, and ocular surface is better for healing. But then in combined single surgery, less follow-up, lesser cost. So especially some patients like who come on the camp and who are not going to follow up again, whether we are going to do that. If we are going to do that, what are the tips for the combined surgery? How do we do the calculation? Because the K is going to change because of pterygium extraction. And how will be the steps that we follow? And would this decision change whether it is a primary or a recurrent pterygium? So with these things, I'll just call upon Dr. Jayalakshmi to show her video also. So it was my case was a pterygium with, which was on the side, and after extraction, the residual scar was a little away from the center, and I did not have much of a problem doing the cataract surgery. So here is another scenario where it was a very scar involving the visual axis. And over to you, Dr. Jayalakshmi, to show how you managed it.
Good evening all. So we all know pterygium with cataract we have always come across in many rural patients, especially because they have their outdoor activities, especially outside and under the hot sun. So I'm just sharing you one such difficult patient I had recently. So this is a 81-year-old gentleman from a remote village. He came for the left eye diminution of vision with 2/60 vision. Had a significant fleshy pterygium, you can see. It's almost coming near the visual axis, and with a brown-black cataract sitting inside. So the plan was to first remove the pterygium with conjunctival autograft and followed by cataract surgery on a later date. So 3 months post-op, this was a picture. He was left with this kind of scar, and topography showed around 6 cylinder. So with this in mind, with the age taking the age into consideration, 81-year-old with a poor view, with a black cataract inside, and with a non-dilating pupil of around 4 mm, I decided to go with extracapsular cataract extraction. So this is a short video about how we went about it. So capsulotomy was the first difficult one. The superior part I had to do under a light pipe, and I made it sure that I release the capsule all around without leaving any tags. And then after releasing it, the second difficult part was to remove the excise of conjunctiva, where you can see it is adherent near the place where the pterygium was excised. And then I made a corneoscleral section and then entered, and you can see a brown-black cataract bimanually I had just coming out. And then the most difficult part was the cortical aspiration. So I wish I had a third hand to hold the light pipe also, but my assistant was doing a good job. So with the Simcoe, I could aspirate the very sticky cortex, which was even adherent to the capsule. So I went about very slowly. I didn't want any complication of PEC rent or vitreous loss at this stage, because the cortex was was not very fluffy. As I said, it was very adherent. And then I made sure that I could aspirate as much as possible from all around. So then finally, after making sure that it was completed, I again went inside and saw the fibrosed capsule, which was the anticapsular capsule which was there, and then implanted the IOL, and then again checked whether haptic was inside, and then sutured the section, and I had to really oppose the conjunctiva with the suture on the nasal side. So at the end of the day, I could sleep well, and the patient was happy the next day. So the questions that Srivalli had asked was the same. So again, when do we go about doing a combined surgery, and how do we calculate, if at all the combined surgery was planned, how do we calculate the keratometry value if the topo is not available? I call upon Dr. Rama Rajagopal for the...
So before we get into the pterygium, I just want to tell SKR sir that if I'm probably more lucky than what you are, I would say. 25 years ago when I stepped in, I was very lucky to have SKR sir as my mentor, and even more luckier because there were 2 more people, Dr. GS and PP ma'am, who are around to help us and bring a very structured approach to the whole thing. Forever grateful, sir and ma'am. So as far as the pterygium is concerned, I think the 2 important aspects have already been covered. One is the decision making, and 2 is about how you go about a case. Let's look at some scenarios, because that's what we see in clinical practice. First, let's say there's an elderly patient who has a significant cataract, insignificant pterygium, who wants cataract surgery. The answer is very simple. You're just going to go ahead and do the cataract surgery. Second, go ahead with the cataract surgery without doing anything with the pterygium. Second situation is a similar patient, elderly, cataract, has a pterygium, but is not very comfortable with the pterygium, although it's insignificant, say, not cosmesis, maybe irritation, discomfort. So this is a situation where extremely rarely you may combine the 2. But please mark my words, when you combine the 2 surgeries, there are a few things that you have to keep in mind, and we do this very, very rarely, okay? So here there are 2 important aspects. 1, your surgical decision. 2, post-operative care. Surgical decision, I think, obviously you'll do an intraocular surgery first. You do the cataract surgery first. Can do a clear corneal if you wish, because if you see in JR's case, there are some limitations about scarring when you open superiorly, especially if you're going to follow it up with follow the pterygium with the cataract surgery. You can take the graft from superior, bulbar, inferior, depending on what is going to follow thereafter. But when you're combining, you can take it from either of the locations that you wish. In terms of post-operative care, I think you must remember, on one side you have a small defect, on the other side for the cataract you need the steroids going. So either you keep the steroids to whatever is required at a minimum level if possible, if you have had an atraumatic surgery, or you patch the patient between topicals, or lastly, you can increase the lubricants and ointment to enhance the epithelial healing. So the bigger issue is about the healing and use of steroids when there is actually an epithelial defect when you're combining the two. Like I said, there's a rare situation where we'll have both. Let us look at a scenario where the pterygium is significant. So you have a significant pterygium. So you know there is astigmatism, keratometry Myers are showing astigmatism or bit of distortion. And this is a middle-aged patient who might require cataract surgery, say 6 months or 1 year from now. So in this situation, you're straight away going to go ahead and excise the pterygium with a conjunctival graft, and you have enough time for stabilization of the astigmatism. Depending on how much astigmatism you had, what kind of regularity of the surface has been re-established, studies say that anywhere between 3 months to 1 year it takes for stabilization of the astigmatism. So in this case, you have enough time to understand whether the keratometry Myers have stabilized. And if a patient wants a toric lens, if you have a smooth surface, regular astigmatism has already been said many times here today, then you can plan depending on the requirement of the patient. Suppose you have a patient who requires surgery in 3 to 4 months, moderate cataract, pterygium significant, then it does not mean that you cannot operate. Like in Jaya's case, I think she had did the case after 3 months. But what you have to do is, if you have a patient with a lot of expectations, at least ensure the refractive stability has happened. Repeat the keratometry 1 or 2 times, and then ensure the stabilization has happened before you consider cataract surgery with or without toric, again depending on the requirement of the patient and the regularity of the surface. The last situation, I think, is a patient who has significant pterygium, significant cataract, does not want to have 2-stage procedures, like what Srivalli said, wants to have both at the same sitting, fully understands that the astigmatism is probably going to remain. Here, the surgical technique is the same as what I described in the second case, but what is important is a little bit of IOL power calculation adjustment. Although the cylinder is going to come down, we really cannot predict how much is going to come down because you're doing a simultaneous procedure. When you have a pterygium, you have a flattening of the surface that happens. Many a times it's a withdrawal astigmatism that you have. So when you remove it, there is a certain amount of steepening that comes with the surface, and so a bit of myopic shift. So you may want to adjust that little bit of myopic shift that might happen in your IOL power calculation. So these are, I think, broadly the guidelines that based on which we decide. If you come to the surgery, I think she did everything. Like in any corneal scar, visualization is going to be difficult. So if you have a moderately dilating pupil, sometimes I even put the hooks, because once the visualization becomes where it becomes, if pupil snaps, then it becomes difficult for you to see. Trypan blue and I think light pipe are things that we do in any condition where the corneal visualization is not very good. I think the discussion also about the toric or a regular lens, we've already covered now, and many people have already discussed that. So in most cases, when you have a regular astigmatism, a stable error after pterygium surgery, then you may want to consider it if and only if the patient is keen on toric lens. I don't know if there are any other questions or any points that I've missed.
Anybody else has any other doubts? Ma'am has explained everything. So, but just to sum it up, actually in a combined surgery, in case if it is a camp patient or something, maybe just to dissect out the pterygium, do that corneal clearing, then you go into the IOL because your globe will become soft. Would that be better? I mean, for the students who are doing it in a camp situation, just to remove the pterygium and then put the graft as the last thing after you finished your IOL.
You can do that.
Yeah, formed globe. Because if you enter and then you start scraping it, then your wound starts leaking. So maybe that.
Yep.
Till the untouched cornea, the visibility is better. When you do intraoperative manipulation, you want a clear cornea. So I always do the cataract first and then touch the pterygium.
Yeah, I was talking about learning surgeons, not experts like you. So that's what is.
No, the more you have to see better. So that also becomes important.
But if they're doing combined and the pterygium is obstructing them, like just removing the pterygium.
But you don't want to mess up intraoperatively. That's,
yeah, I know.
That's great.
So they better not mess up intraoperatively.
So are there any practical questions from the postgraduates? I said from the postgraduates.
Everybody, when SKR sir is around, Prema is around, everybody is So you rightly spoke about the need for quick epithelial healing in these cases, all the more because we can't dispense with the use of steroid. apart from patch between topical, I have found it very difficult to use any size bandage contact lens after pterygium surgery and autograft, because even the larger lenses, sometimes they straddle the autograft and the part which is outside the autograft kind of balloons out.
Correct.
So is there any simple kind of solution to, does anybody use bandage contact lens to heal that epithelial defect after pterygium surgery?
I rarely combine the two, first of all, and if at all I don't use, because usually it's a very small insignificant pterygium in these cases, if at all you're combining, where the defect is going to be very small. Just with patch between topicals or increasing lubricants, you're able to get away.
The bigger problem gets addressed and the other one later.
Okay, so we'll move on to the next case, and if there are any doubts, we can take at the end. So the next is a case presentation by Dr. Ratni, where she had a patient of glaucoma, but who had a corneal edema, and then she had a dilemma, and Dr. Radhika ma'am would be the discussant.
Good evening. I will be presenting a case on corneal edema with glaucoma and cataract. So this was a 62-year-old male who had complaints of blurring of vision for the past 1 year with very high baseline intraocular pressures, and he was on treatment for glaucoma for the past 1 year. So his best corrected visual acuity was 618 N10 in the right eye, and in the left eye was 612 N6. He had a decompensating cornea in the right eye. In the left eye, his cornea was relatively clear and compact with a few gutted changes, and his anterior chamber was shallow in both eyes, and he had a RAPD in the left eye. He had grade 1 to 2 nuclear sclerosis with cortical changes in both eyes, and his intraocular pressure was 15 millimeters of mercury and 16 millimeters of mercury on 3 anti-glaucoma medications. His gonioscopy, the view was hazy in the right eye. Left eye had 360-degree synovial closure. His optic nerve head showed severe glaucomatous optic neuropathy, which was worse in the left eye. So this is a picture of the right eye showing corneal decompensation. Left eye was relatively more compact with gutted changes and the beaten metal appearance. So his specular in the right eye was about 685 cells, and in the left eye was 1563. With features of polymegathism in both eyes, and with a pachymetry of 820 microns in the right eye and about 657 in the left eye. His ultrasound biomicroscopy showed an anterior chamber depth of only 1.3 and a thick lens which was greater than 5 millimeters with peripheral anterior synechiae all around. So we came to a diagnosis of primary angle closure glaucoma with Fuchs endothelial corneal dystrophy with a decompensating cornea in the right eye. So some of the dilemmas that we faced in managing this patient were because of his advanced PSCG on 3 medications with a decompensating cornea in the right eye with very low specular counts and with a very high CCT of 640 microns in the left eye despite the cornea being fairly clear and a thick lens. So what are our management options for this patient? First, do we go ahead and do a YAG PI? Or in the right eye, which is already having decompensation, do we directly do a trabeculectomy followed by a DMEC phaco-IOL as a stage procedure? As for the left eye, do we first do a trabeculectomy or a phaco-trabeculectomy, considering his lens was very thick, then followed by a DMEC phaco-IOL, or first a DMEC phaco-IOL because his CCT was more than 640 microns, followed by a anti-glaucoma surgery. I'll leave the case for discussion. As for the right eye management.
So basically, I think you have to answer the first question, because this was a chronic angle closure glaucoma with very little working space, whatever surgery you do, and the pressure was also on the higher side. So I think it would make sense either to go ahead with the trabeculectomy, which will have a PI incorporated in it, or do a PI followed by a glaucoma procedure. So I think in this case, a glaucoma surgery would have to be done first before addressing anything else. Ratni and I had a bit of discussion about the case even before we presented it here. So I think the cataract surgery was avoided during the trabeculectomy, A, because the pressure was very high, and B, because the cornea had already started decompensating and the visualization was poor for you to do the cataract surgery. So I think the solutions kind of played out on their own. So you did the trab first because the pressure was high. You did not do the cataract surgery at that time because the visibility was low. And subsequently, the patient underwent endothelial keratoplasty along with a cataract surgery. But indications-wise, I think as was discussed in the guest lecture followed by PMAM's comments, indications-wise, specular count is the least of your priorities. If you did have clinically confident central data, and if you did see, you rightly mentioned the beaten metal appearance. You know, many people kind of overlook that. That means that the decimates is definitely unhealthy. More good data would come. The decimates may strip during your intraocular procedure. So if you did see these, and if the central to peripheral pachymetry ratio, as was pointed out earlier, are approaching each other. And if you could, then you would apply Dr. Patel's 3-point criteria. So if all this pointed towards a worse fuchs or a going to decompensate fuchs, then probably combining an endothelial keratoplasty with the cataract surgery will be done after the glaucoma procedure. One small indicator that I use to decide whether the guttata mean anything at all or not is also to use the imaging with the ASOCT. Many times, corresponding to the beaten metal appearance on the slit lamp examination, in these patients who have just guttata versus people who are likely to decompensate, the decimates does show a bit of different hyperreflectivity if you look for it. That is also an indication that this is an unhealthy decimates, which along with the other criteria mentioned will help you to decide about the nature of the surgery.
Controlled in the right eye. If we just do cataract and DMEC. Cataract surgery is supposed to also reduce the pressure.
This patient was on 3 medications.
3 medications
Was
with advanced glaucoma, ma'am.
So then there is no other.
Yes, ma'am. So we took a chance and did trabeclectomy first with the careful post-operative manipulation, because shallowing of AC is one of the dreaded
That's what.
complications.
Once you knock
Yes,
off the
yes.
thick lens, if the AC shallowing is going to improve, do you think you could have stepped down the medication post-operatively? Is what I'm trying to.
We might have had to decrease it, because we couldn't give him we wouldn't have been able to give him the whole array of medications after the DMEC, ma'am. But then there's every chance that his glaucoma might have progressed, and the endothelial loss can also be more if the intraocular pressure is not under adequate control.
Whether the cataract surgery itself will have a beneficial effect on the glaucoma, the way I understand, I'm no glaucoma expert, it is applicable in a very early open angle kind of glaucoma. But otherwise, in advanced glaucoma, where you have a shallow chamber with 3 medications, I wonder if cataract surgery will provide that much beneficial effect on the IOP control. Correct me if I'm wrong.
I think it works more on an angle closure glaucoma rather than an open angle glaucoma, because the angle opens up once you remove the lens.
That's why I thought.
The change in IOP in an open angle glaucoma is very minimal, but having a pressure of 36 and 3 AGMs, you are not going to get away with just knocking off the lens. You could have done the cataract surgery with the glaucoma surgery, but that would affect the success of your trap. We do, again, your visibility would have been an issue, because you don't want to debride the epithelium. If visibility was an issue for you when you're doing a trap, and 3 months later I have to do a DMEC or a DSEC, the visibility is going to be more of an issue even for me to do the surgery. But the only thing is, yes, you can debride the epithelium and see, but when you're doing when you're replacing the endothelium, we are more sure that the pump is going to function up and the endothelium is going to heal. Whereas if you're debriding an edematous cornea without having a functioning endothelium, that epithelium will take longer to heal, and that would be more of an issue. If it was a harder cataract, you can even do an SICS with a trab if you feel that the lens is large and you want to remove it. DMEC would have been easier if the cataract was done. I would have to not have to struggle less to do the DMEC if you had removed the cataract. So it's basically in terms of how your success of your trab is going to be when you combine it, versus how your success of DMEC when you're going to combine it with procedures. Any transplant, if you're doing it separately versus you're combining it, the success is much better when you're doing it individually as compared to when you are combining it with a cataract surgery.
How is it made to buy some time? Can it be done with your...
Too expensive. Do the procedures which you know is going to give you the best outcome, predictable outcome in your hands.
And this is angle
so
closure.
you would do a trap. Is an indication?
No, not an indication. The other eye, however, we did do phaco trap, and the cornea is still holding up so far.
The other thing is your corneal edema might actually be more when the pressure is high. So you would probably want to assess the cornea also once the pressure comes down before jumping into a corneal transplant. Here you had guttate changes, so you were fairly clear that it's a decompensated cornea.
So I think all cornea people agree it's a glaucoma case. Please control your glaucoma, and then we will look into whether the edema, what we have to do. So right, with that,
eye also becomes very important. If you can't appreciate the guttata or the cornea has already decompensated in the eye in question, then taking a look at the other eye to look for changes also becomes important in the district.
So yeah, thank you. We move on to the next case presentation by Dr. Durga, a patient of cataract who had severe dry eyes, and for the discussion we have Dr. Bhaskar with us.
A very good evening, everybody. So, a 61-year-old male, he came with a severe complaints of watering, itching, and photophobia and blurring of vision for the past couple of months. He gave a history of cataract surgery in the right eye 9 months back, and it was done outside. And otherwise, the systemic history was unremarkable, and he was on multiple drops in the same eye. On examination, his vision in the right eye was 618 and 12, and left eye was 612. And he was accepting 6.75 diopters with a -1 sill in the right eye, and the left eye was 0.75 with a -0.75 sill. And on slit lamp examination, he was extremely photophobic, and he had some meibomitis, but there was no corneal staining and a pseudophakic eye in the right eye. Left eye, he had meibomitis, and there was no corneal staining with an immature cataract. The tear breakup time was reduced in both the eyes, and the Schirmer's was normal in both the eyes. Otherwise, the TMH was normal in both the eyes. Syringing was patent. And the fundus examination was apparently normal. I would like to say that patient was extremely photophobic, that even to examine during the routine exam was in the OPD was very difficult. Sorry, I could not click a picture. And we did a re-refraction, and he was accepting 8.5 diopters in the right eye, and left eye was plano. He was improving, with that he was improving to 6.9. The Myers were clear in both the eyes. So to summarize, we have a patient who was unhappy post cataract surgery in the right eye with the vision, whether it's probably a wrong IOL or a DBR surprise, and symptomatic about watering and photophobia, with the breakup time being less but the Schirmer being normal, with a significant cataract in the left eye. So my questions to our expert is this dry eye? How should I manage him? So does a dry eye affect the DBR, and when to operate him? Which eye first? Either IOL exchange versus cataract surgery, and do you consider MF IOL or a premium IOL in such patients?
So this patient, the history of cataract was about 6 months back. His history of discomfort, from what your history said, was about 3 months back. Probably dry eye related, because your patient is very symptomatic. If it's only an IOL surprise in terms of the 8, he will be unhappy with vision. Unless he's complaining of positive or negative scotopsias, which are more classical in terms of the way that they describe it. It will not be like they are very photophobic in that sense. They will give you positive or negative scotopsias as far as your lens edge design is concerned. So this patient is symptomatic. You need to find out what is the cause for his discomfort. In your investigations, you said MGD, you said tear breakup is fast. So when they blink a lot, they might, even if your Schirmer's is normal, you might actually not see staining. I mean, if it's slow, you might not see staining on the surface because they are compensated by blinking, so their surface is kept moist. So if your Schirmer's is good, but you have a significant MGD, then again you're trying to stabilize your tear film by blinking more. So here I would have probably liked to do a detailed evaluation, look at the, in a clinical, as far as a general ophthalmologist is concerned, I would want to press the lids, look at the consistency of the mebum that comes out, look at the number of glands that are patent. That would give me an idea as to how bad the MGD component is. Once, if you are in a as a specialty clinic, then I would probably want to get a keratograph or a lipid view done. Again, if it is very symptomatic patient that he's not, you're not able to take photos, we might not get very good lipid layer thickness, because the lipid view requires a large, bright light for it to focus on the cornea. It might not be possible, but at least you will get an idea about the anatomy of the meibomian gland. So whether there is gland loss. The MGD is described by two components. One is the amount of gland loss anatomically, and the second would be the amount of lipid that is there on the surface. So from a general practitioner point of view, a simpler way would be to press the lids, look at the quality and quantity of mebum that gets expressed. So that will help you understand what this is. The second reason could be some kind of a blepharospasm, which could also mean that he is blinking. So you need to differentiate between a dry eye and a blepharospasm. If you have an access to a pros lens, you could put a pros lens. If the blinking is reducing, that means once you are reducing the symptoms of dryness, the spasm is coming down, you know it's a dry eye related problem, and you address the dry eye. You don't have an access to a pros lens, you can put 1 drop of paracaine. You are reducing the sensations which go from the eye, and the spasm reduces. You know it is probably related to the dryness. If it doesn't change with a pros lens, or it doesn't change with a paracaine, and you are seeing facial muscle spasms also, then you know you're dealing with a blepharospasm, in which case you would be looking at doing a Botox, reassessing the dryness subsequently, and then treating it as such. So this patient probably had MGD, which was missed at the initial stage. At this point, if he comes back, we'll probably be looking at imaging him, offering him maybe an IPL or a LipiFlow to see how that makes a difference. A use of fluorescein is very important, because even a mild ATD component will make the patient symptomatic. So when you see any cataract patients, make sure that you put a drop of fluorescein, evaluate. You're not just looking at the staining of the surface, you're looking at the breakup, and more importantly, if you keep looking at normal patients, you will start estimating what is a normal tear meniscus height, what is a low tear meniscus height, and that kind of tells you whether there's a ATD component also. You don't have to really rely on Schirmer's all the way, but you need to keep seeing it in all patients. As far as dry eye and multifocal lenses are concerned, if dryness itself is going to cause a problem with respect to the quality of vision, multifocal lenses have their own drawbacks. There is no contraindication in a sense. It's not that it cannot be done, but you would want to address it. Again, if you are looking at a patient who's a Sjogren's patient, who's say on HCQ or any medication which can cause macular changes, then I would not be too comfortable advising it. I would probably opt for something like the advanced monovision lenses rather than opting for a pure multifocal. If you decide to go ahead with a multifocal, there has to be a fairly detailed discussion, more than what you would have with a normal multifocal patient, because if he or she becomes unhappy, they go to the next doctor who says, you have dryness, you should not have had the multifocal lens in your eye. And if that patient then comes back, it becomes very difficult to reconvince him that we had the discussion. So your chair time, if you are deviating from any normal protocol that you are doing a multifocal lenses, has to be much more than what you would have with a normal patient that you are doing a multifocal, which again has to be much more than a normal patient that you would do a single focus. The advanced monovision lens gives us a trade-off, because if you can do a micro monovision, you can probably give the best without having to spend that much chair time, but you would probably aim for a plano in one eye and maybe about a 0.75 in the other eye, and tell him that he'll probably still need a 1 for reading books, but he might get away without glasses in terms of cell phone usage. As far as DBR is concerned, yes, any change in the tear film can affect the DBR. Putting a drop of paracaine can affect the DBR. So if you are looking at premium lenses, or you're looking at upgrading your refractive endpoint, you have to improve the ocular surface, make it as normal as possible before you do the surgery. So if you feel that you have significant ocular surface disease, treat the ocular surface disease, then do the DBR, and then do your cataract surgery. As far as the details in terms of cataract surgery in a dry eye is concerned, whether you want to use a scleral section, whether you want to use a corneal section, again that's a completely different debate, but each have their own advantages and disadvantages. You follow whatever you are comfortable with, but the threshold for using sutures, if the incision is slightly leaky, is less. You would not use NSAIDs in these eyes because they are more prone to epithelial healing issues. Intra-op, your visibility because of the desiccation of the epithelium is going to be an issue, so you might want to coat the epithelium with viscoelastic. So we've mentioned most of this in our article in IGO, which you can freely access on review of not just dry eye, various ocular surface diseases as such. So most of the things which got discussed in terms of the pterygium and this can be understood once you read the article. There is an ASCRS guideline for cataract and refractive surgeons, where you can look at, when you look at the patient, you look at any lumps or bumps in terms of any chalazion, or you're looking at lid laxity, or you're looking at SLKC. So you want to make sure that you are addressing that. Try to look at diseases which can cause a visual dysfunction, treat that, and then do the cataract surgery. Any surface which is irregular, your outcomes of cataract surgery is going to be suboptimal. Optimize the surface and then do your cataract surgery. Unless it's a total cataract, cataract is not an emergency.
Thank you so much, sir. Any other questions? Thank you so much. Wish you all a happy Navratri. Thank you.
Thank you. Thank you very much for the detailed explanation. If Dr. Bhaskar has to explain about dry eyes. It cannot definitely be done in 10 minutes time. And so, but my just one question was 8 diopters refraction. So yeah, so whatever tear film does, I really don't think 8 diopters would have come. So I think that is some error somewhere or a wrong IOL. Yeah, so that is definitely not, can't blame everything on dry eye, right?
The surgery was done outside. It's Sir, you want to say something?
Bhaskar.
Dr. TSS wants to say something.
Oh, sorry. Yeah. So it's a high error. So if I have to do a laser, it will probably be a LASIK. I would probably prefer just putting in a add-on lens in the sulcus, probably a sulcoflex kind of a thing, as the first choice. He has dryness, so I don't want to be doing anything on the surface in terms of LASIK or PRK. In terms of the other option would be to remove the lens and exchange it, which is possible, provided there is not much of scarring and his bag, everything is stable. If he's already had a PCR or something of that sort and the lens is dangling, then both of these options are out. Then you have to remove the lens and then be prepared to put an SFIOL of the appropriate power. Or if you have some rim, you will be able to get away with another lens. But if you are removing the lens, you might want to cut the lens so that the incision is smaller, if it's a non-foldable lens.
Thanks everyone for staying back throughout. And any final questions, any questions? Any comments by anybody? Yeah. The quantified IOL, I think, on the table and replace if required.
We have an ORA.
He's saying put the IOL, do a retinoscopy, and then if it is not coming as plano, then to change it. I think before the age of DBR, this was what was supposed to be done, that people would take out the cataract, do a retinoscopy, then calculate the IOL and put it. So I really admire those surgeons because they were operating without these kind of microscopes. They were not doing phacoemulsification. They didn't have viscoelastics like the way we have. And still, if their corneas were so clear after they have removed their cataract, to do a retinoscopy, I mean, wow. There
was a machine also, ORA, which kind of came up in between. But once the ACRS calculator has become much more predictable, we've not had to venture into buying that.
I request PP ma'am to give a small memento to the speaker, Dr. K. SKR.
Would like to conclude by first of all thanking Dr. Shikha, who is the one whose baby this cataract update is. She's been doing multiple versions of it. Yeah, since 2014 was it? Yes. So 10-year-old baby now. So, thanks a lot, Dr. Shikha. Thanks to the multimedia team. Even though we did have a few glitches, I think the YouTube link also started working, and then people have been watching and saying that it was audible, and the presentations, the things were nice.